please, you can.
Yeah, please go ahead.
Yes, I'll let you know. So we can start. You can start.
Okay. So, good morning, everyone. On the behalf of Cipla Pharmaceutical, I, Kumar Kaushal, would like to welcome all the doctors in this meeting. Today, we have with us Dr. Abhijit Ray. Sir is a renowned senior consultant and rheumatologist from Kolkata with over 30 years of experience in general medicine and rheumatology medicine. Sir has received several awards and recognition for his work in the field of rheumatology. Today, Sir will be speaking on the role of TNF alpha inhibitor in ankylosing spondylitis. So without making any further delay, I would like to request Dr. Abhijit Ray. Sir, please enlighten us with your knowledge. Over to you, sir.
Thank everybody. On behalf of myself, let me thank you all for sparing your valuable time on a Sunday morning on this interesting topic, ankylosing spondylitis and role of TNF alpha inhibitors, which has been used for about 20 odd years. Spond, as you all know, is a prototype of spondyloarthritis, an interrelated group of rheumatic diseases that share some common primary clinical features, such as inflammatory back pain, associated with morning stiffness, difficulty in turning in bed at night, buttocks pain, etc. Peripheral arthritis, which can be asymmetrical to start with, and it can involve mainly the joints of the lower limbs as well as the fingers and toes. Enthesitis, characteristic symptoms of angspond, along with spinal stiffness, loss of spinal mobility, which we check with our scores, structural damage due to extensive osteoproliferation. The general treatment of AS should be tailored according to current disease manifestation. Is it purely axial, peripheral, anticial, or extra-articular? Extra-articular would include something like osteoporosis, and also the cardiovascular mortality is high in spondyloarthritis. Level of current symptoms, the clinical findings of the patient, the prognostic indicators that he has. His general status, the age. It's a disease of young men below the age of 45, predominantly, but we know that a lot of ladies also do have spondyloarthropathy, though some of them may not progress. The gender, male gender is important. Comorbidities like osteoporosis, cardiovascular, associated uveitis, skin problems like psoriasis, inflammatory bowel disease, all of them are part of the thing. Concomitant medications which the patient is having, psychosocial factors like stress can also exacerbate the disease. Approved biologics in India for axial spondyloarthropathy is infliximab, golimumab, adalimumab, etanercept. We have not got Cimzia or certolizumab pegol. It has never come to India so far. IL-17 inhibitors, which we have is secukinumab. Ixekizumab is on the pipeline, so it should be available soon. Then we go to this very interesting chart. AS-EULA recommendations for the management of axial spondyloarthritis 2022 update. You have a clinical diagnosis of axial spondyloarthritis. If symptomatic, you can start the patient on non-steroidal anti-inflammatory drugs with the maximum tolerated dose. With the maximum tolerated dose, it should be at least 2 courses. And the evaluation should happen at the end of 4 weeks. Along with physiotherapy for all patients, education is important, regular exercise, and stopping smoking. Tobacco is a great concern to us. So after 4 weeks, if there's an insufficient response to axial spondyloarthritis, if failure in phase 1, we'll go on to phase 2. But if it's sufficient response, we continue with the existing management. Now in phase 2, if it's mainly peripheral symptoms, like an ankle or a knee, then we can consider local glucocorticoid injection and consider sulfasalazine as a disease-modifying drug. But it can often lead to the ASDAS, which we are doing in our day-to-day practice, the ASDAS CRP. If it's showing high disease activity, more than 2.1, and a positive opinion on our behalf, then we have the option of starting TNF inhibitors, IL-17 inhibitors, or latest addition JAK inhibitors. But in view of a lot of experience with anti-TNF over the last 20 years, we normally prefer anti-TNF. In the case of psoriasis, we can definitely choose IL-17 inhibitor as a first choice. But normally, history of recurrent uveitis or active inflammatory bowel disease like Crohn's disease or ulcerative colitis, which is about 5 to 10% of our patients, the monoclonal antibody TNFs would be preferred. In our case, adalimumab or infliximab. And we evaluate again the patient after 12 weeks, which means after 3 months. And if the ASDAS has done well, it has come down, we continue with it. If the FDAS is still high, we go on to phase 3. In the phase 3, we know these people, they have lacked efficacy and toxicity, or because of toxicity in phase 2, ASDAS is high. So we can switch to another biological demand like TNF inhibitor, another one of the same class, or we can switch to an IL-17 inhibitor. Or if somebody prefers an oral drug, JAK inhibitor, we again evaluate after 12 weeks. The ASDAS should be coming to low disease activity or inactive disease. If not, then we have to rethink our programming. TNF inhibitor and IL-17 inhibitors are recommended after failure of conventional treatment, which means NSAIDs, physiotherapy, and sulfasalazine for the peripheral variety. So, TNF inhibitors. Over the past decade, or maybe 2 decades, I would say, TNF inhibitors have revolutionized the management of AS, and it significantly reduces the signs and symptoms of AS. And we have the 4 options there: infliximab, etanercept, golimumab, adalimumab. Role of TNF inhibitors. SAS-20 response with TNF inhibitors as reported in respective phase 3 trials. Infliximab, SAS-20 between weeks 12 to 24, 60% at least responsible at week 2. Golimumab about 59% as early as week 4. Etanercept 60% as early as week 2. Adalimumab 58% as early as week 2. Next, disease activity inhibition. The BASDAI score with TNF inhibitors are reported in the respective phase 3 trials. And the BASDI reduction has been significant with all of them. All the infliximab, golimumab, etanercept, adalimumab have had significant response on the BASDI. And with functional improvement in the patients, the adalimumab is remarkable, -1 point. Golimumab, again remarkable. Infliximab. So you can see these drugs do work in our difficult patients. SF36 PCS score from physical component study that we have done in respective phase 3 trials, the adalimumab is 10.2, infliximab 10.2, it's identical. SAS40 response in AS patients with TNF, you can find a very satisfactory response for the first 4 drugs. Certolizumab, we haven't got in India, but the remaining 4 we do have, so we have a good choice there. Now, efficacy of TNF inhibitors in patients with Ankylosing. The distribution of the enthesitis scores, the patient global assessment, ESR and CRP, according to the groups of baseline and third. Enthesitis score, a good response from infliximab, etanercept, and adalimumab in the data. Patient global assessment, a similar thing. All the 3 have done very well. ESR decrease. Before it was 24 to 34. It has significantly reduced to 8 to 14. So very significant reduction after use of these agents. CRP, which was as high as somewhere between 13 and 11, has substantially reduced to about 3 or 4. So a very satisfactory thing for most patients. So statistically significant improvement in patient global assessment, ESR and CRP, was observed in each of the 3 TNF blockers which we used. A statistically significant decrease in the enthesitis score at the end of 3rd month was observed on etanercept. P was 0.003 and ADA was 0.041 and 89.8 and 93.2% patient achieved SAS20 response at 3 months and 6 months respectively. So the patient is getting a good deal. No statistically significant difference in the SAS20 and SAS40 response rates among the 3 TNF blockers. From the DASIR cohort, the daily practice regarding active sacroiliitis, if a patient has sacroiliitis on MRI compared to placebo, which has out of 62 patients, only 9 had some accidental response. For for TNF, it was 37 out of 80. But patients without sacroiliitis, they did a little less better, but they did better because it was 17 up from 127, increasing to 24 to 130 according to the data. Next. So the inhibition of structural progression, prevention of structural damage is one of the key treatment goals for patients with axial spondyloarthritis. Spinal radiographic damage is shown to be important determinant of spinal mobility and functional improvement. But the relatively slow growth of syndesmophyte formation and limited sensitivity of conventional radiography has made it difficult to determine the impact of biologics on spinal radiographic progression. That's why the modified ASAS criteria came instead of the previous New York criteria, which depended on X-rays alone to document AS. Now we have included the MRI, and that has made a huge difference, along with the parameters of CRP, ESR. Inhibition of structural progression over 2 years. Over 2 years, the TNF inhibitors had no effect on structural progression inhibition as compared to patients not receiving biologics. So at 4 years, again, the difference was not very significant. But at the end of 8 years, the inhibition of structural progression is seen only after 8 years with anti-TNF therapy. So we have to note that a long-term use of these agents will prevent the progression of syndesmophyte formation. The erosions happen, but the new bone formation takes a lot of time. And that's why previously, prior to MLR, we had difficulty in documenting early Ang-Spawn, which we can't do now. Although TNF inhibitors have beneficial effects in the management of Ang-Spawn, up to 40% patients with AS do not respond or are intolerant to TNF inhibitors. Please do respond. Realize that it's a substantial percentage who do not respond or are intolerant, or they have a rapid relapse on discontinuation of TNF inhibitors. Safety. Are there differences among the TNF blockers? If you look at it, tuberculosis, disease-modifying agent, 3,232 patients, patient years 7,345, rate of TB incidence was 0. With anti-TNF, it is slightly higher. Number of patients, 10,712. Patient years, 28,447. TB incidence was 27. And the rate was 95 per 1 lakh. Not very high, but definitely we should be. Remember, we should be careful about, because that's why we screen for tuberculosis with chest X-ray, Mantoux test, TB IGRA, just to rule out evidence of TB. Etanercept is a safe drug. 5,521 patients with 12,744 years. TB incidence was 5. Rate was 39 per 1 lakh. INF, which is infliximab, 3,718. Patient years, 8,069. TB incidence was 11. Rate is 136 per 1 lakh. It is quite slightly higher. And compared with adalimumab, which is the most commonly used drug, it's 4,000 plus, patient years 7,000 plus, TB incidence again 11, 144 per 1 lakh rate. 13 out of 40 reactivations occurred after withdrawal of therapy, while 25 out of 40, 62% of cases where extrapulmonary TB was detected, and 11 were disseminated TB. Risk of TB activation, the absolute risk and the estimated absolute risk increase of TB with TNF inhibitors in India. We know India is a TB endemic place. The absolute risk is 168 per 1 lakh in the general population. With TNF inhibitors, adalimumab 4,922, infliximab 325. So a higher number of patients are at risk of developing TB with TNF inhibitors in India. The important thing is we are always screening for tuberculosis prior to including these patients in with these drugs. And the risk of immunogenicity is higher with infliximab, 6.1 to 69%. These monoclonal antibodies, because you know it's a murine antibody, a partial chimeric antibody. Adalimumab is the humanized form, that is 8 to 39 as compared to infliximab. So infliximab is perhaps more immunogenic than adalimumab, so both have their share. TNF inhibitors increase the risk of both first hospitalization and exacerbation of heart failure. For this reason, TNF inhibitors are contraindicated in patients with New York Heart Association, class 3 and class 4. So benefits of human necrosis factor inhibitors. for cardiovascular disease in ankylosing spondylitis. This was a recent paper published as late as November 22 in the International Immunopharmacology Journal by a Chinese group. And the main motto was cardiovascular disease risk is increased in ankylosing spondylitis. Inflammation and metabolic dysfunction induce endothelial activation, which leads to cardiovascular disease. High-risk patients for cardiovascular disease would benefit from tumor necrosis factor inhibitor treatment. The risk assessment, including prediction scoring, the serum lipids, and subclinical atherosclerosis by ultrasound, which included carotid intimal thickening, gives us a clue. Surrogate markers and non-invasive microvascular assessment tools would facilitate evaluation. So the take-home message is tumor necrosis factor definitely helps in preventing the cardiovascular complications of spondyloarthropathy. Now, this is a very important slide predicting the probability of the response to TNF factor inhibitors for individual patients with ankylosing spondylitis. This came out in JAMA Network by Michael Ward et al., March 22. So last year, 1,899 patients from 10 trials, out of which 1,207 were chosen with an age of 39, and the mean age was 39 years, but their variation was 12 years. 75.2% were men, 24.8% were women. Out of this cohort, which was treated with anti-TNF, the major response, 33.7%, which is 407 out of 1,207 patients. The accuracy was 0.74. The probability of using anti-TNF and getting a good response is high, with a raised CRP, patient global assessment, and a BASDI at least 2 or more. So this is a very important parameter before you embark on anti-TNF. You are thinking about which is the gentleman or the lady who would respond to your anti-TNF therapy. And if they have the 3 criteria, raised CRP, increased patient global assessment, and a BASDI at least 2, they have a better chance of getting response to treatment. You must remember that biologics are expensive. No response, 34.3%. Accuracy again was 0.75. They found people with a higher body mass, increasing age, and an increased BAS5 score, which means as the disease becomes more advanced, the response of anti-TNF may not be that satisfactory. And the importance, think about this cohort study, the probability of initial response to TNF inhibitors was predicted from the baseline variables, which may facilitate personalized treatment. You are giving personalized treatment to your own patients, and so you are chalking out those guys who would benefit from the therapy. This is a rather complex thing, came out in April 2022 last year. Baseline serum biomarkers of inflammation, bone turnover, and adipokines predict spinal radiographic progression in ankylosing spondylitis. And from the Judith Rademacher et al., and they suggested that the biomarker levels of 137 angstpon patients in a German cohort, Groningen-Leeuwarden axial spondyloarthropathy. The spinal radiographs of these patients were scored at baseline at 2 and 4 years, and it was measured with logistic regression. Inflammation, the MSAS was greater than 2 points would show on the X-rays. Calprotectin, higher level of calprotectin predicted new syndesmophyte formation after 2 years. MMP3, matrix metalloproteinase 3, PEGF, all these three will give something. Bone turnover marker, like bone-specific alkaline phosphatase, SCTX, which is serum C-terminal telopeptide type 1 collagen, showed increased syndesmophytes after 4 years. You must remember, Angst is a slowly progressive disease. And to catch a syndesmophyte progression, it takes time. Raised osteocalcin, OPG, pro-collagen type 1, sclerostin, all are important. Adipokines, like high molecular weight adiponectin, out of which if you have a high leptin, that MSAS increased more than 4 points after 4 years. Visfatin again shows an increased MSAS progression after 2 years. But this is more in the lab and in the research centers. But we will keep in mind that in future, some of the biomarkers should be available to us so that we can gauge the rate of progression of syndesmophyte formation or bone formation in these patients. Conclusion is TNF blockers are efficacious in axial spondyloarthropathy. Safety profile of TNF blockers in axial spondylo is good based about 20 years of treatment experience. We have had it more than anti-IL-17 and JAK inhibitors have been introduced later. Radiographic progression can be retarded by TNF blockers if treated long enough and early enough. Then I take you to a rather interesting patient, which takes us to the dilemma which we face in Angst patients in a day-to-day practice. And I hope you have an open mind with this patient. 35-year-old male, body weight is obese, 111 kg, height is 5 foot 8 inches, comorbidities like hypothyroid for 10 years, he is non-diabetic. Present problem was low back pain, swelling of the left ankle and the left great toe. No skin lesions of psoriasis, no GI symptoms or eye symptoms. So no uveitis, no frank inflammatory colitis symptoms. Past medical history, he was diagnosed as spondyloarthropathy by a senior rheumatologist. He has been HLA-P27 detected in 2013 and was initially started with sulfasalazine 500 milligram twice a day. But the patient has stopped his medication after 18 months. Problem with the patients is, as soon as they get a good response, after a few months, they tend to stop. On 2016, he relapsed with a left knee swelling and ankle, which was treated by the family GP with NSAIDs. He had a family history. His mother had low back pain. On examination in February 21, which was just before the COVID, he had a low back pain, difficulty in squatting, a swollen left ankle and great toe. And his modified Schober's test was compromised, 10 centimeter to 13 centimeter. Chest expansion was only 1.5 centimeters. His blood pressure was a bit on the higher side, 156 by 90, as you would expect in a metabolic syndrome patient. Investigations revealed his serology was negative, TB gold was negative, MAN2 negative. Hemoglobin was okay, 13.1, TLC 6,900, platelets 3.56, CRP was mildly raised, 8 out of 5, ESR raised again 25. His cholesterol LDL was 162, triglyceride 120. So he must have been fond of fast food or whatever you can guess, plus genetic background might be there. COVID-19 was negative, ECG was normal. ASDAS CRP came out to be 4.9, very high disease activity. ASDAS ESR similarly 3.8. And his BASDAI was 6.2, as you can see from the measurements. Digital X-ray showed bilateral sacroiliitis. He had a left hip joint space narrowing. Yes, syndesmophytes between number 3 and 4, number 4 and 5. And on February 21, he was started on etoricoxib, 90 milligram twice a day, pantoprazole, his thyroid replacement, sulfasalazine BD, telmisartan for hypertension, Tonac TG for his cholesterol, lipids, physiotherapy. And as you can see, because of the high ASDAS score or BASDAI score, I decided to start him on the first dose of ADA biosimilar, 20th February 21, and I'd given him a chart so that he could have it at home. He was a businessman traveling sometimes out of the city. So this will be a mode of application, which is easy, especially for people who travel. Because if you can pack these injections, you can carry it in your cold and maintain a cold chain, you can carry it with you. 6 May 2021, he was much better. And he was advised to take COVID vaccination as a precaution against the epidemic. Investigation showed ESR substantially reduced to 10, CRP of 2, liver functions mildly deranged, nothing great. ASDAS had come down to 1.7, which is low disease activity. ASDAS CRP was 1.3, borderline, and BASDAI was 1.8. So a substantial improvement from his previous state. I suggested a 5th dose of ADA, 8th of May, 6th dose of ADA suggested roughly 21 days later. Because as you know, because of the economics of it all, we tend to increase the interval between the injections once the people feel better. And the aim was to explain to him to bring his ASDAS CRP below 1.3. So that was the aim. He was doing well. He was happy. So that's the thing. He was lost to follow up because of the COVID and the irregular times that we faced, all of us faced. In September 22, he gets come back with severe cervical pain. His body weight had come down 106 kg right now. His blood pressure 142/98. Investigations reveal hemoglobin 10.9, TC of 7,300, 70% neutrophils. ESR was raised 30, CRP was also raised, and his fasting blood sugar has gone up to 176, uric acid borderline 6, SGPT, SGOT was raised. ASDAS CRP was 3, which has again gone up, high disease activity. ASDAS ESR was 2.9, and his BASDAI was again above 4, 5.2. So I suggested 1 hour of exercise daily. The background thing should go on: physiotherapy, exercise, etoricoxib, pantoprazole, Tyronorm, SAS-DS as a backup, telmisartan, Tonac TG, hypertension control with Concor Core, glyphosate SR mainly for the sugar and the obesity, followed 5 milligram, and then. Now the question comes, the dilemma comes, which faces all rheumatologists and practicing clinicians. Now, which drug to use? He's a busy businessman who wants to travel out of the city sometimes. Should we go for adalimumab, infliximab, golimumab, or etanercept, which is all available to us? Or should we go for a JAK inhibitor, the original, which is available, Xeljanz, or generics, which is available in plenty now and far cheaper? Or should we go for an anti-IL-17? And the question, what do you do when your highly educated patient is less compliant? And with this question and problem in mind, I would definitely complete my talk. And thank you for listening and welcoming any suggestions from your side.
Thank you, sir, for the detailed presentation. Just now, I have come to know that from the team from backend that there are more than 170 doctors across the country who are listening to you live. Now, there are some questions in the chat box.
Yes, let me respond one by one.
Yes, sir.
How can ankylosing spondylitis be diagnosed earlier? we have the latest EULAR is classification, which use the guidelines, where you use, and accordingly, you can definitely diagnose it if you have, and it comes in as an app, which you can keep on your mobile, and then you can diagnose it early and also diagnose the disease activity. ASDAS is pretty easy to do if you have the CRP result or the ESR result, and BASDA is clinical indexes. So next question, are patients early in the disease similarly active compared with later in the disease? The early in the disease, the inflammation part is more important, where the bone is having the erosions, and anti-TNF has a bigger role, along with the conservative therapy if it fails, while later on, once the syndesmophyte comes into the picture, I believe it is more physiotherapy. And as I showed you, the parameters, elderly patient, later in the disease activity, higher BAS5, which means the joint damage is much more, especially if they have the bamboo spine, the response is much less. So catch them early, because we have the advantage of having MRI nowadays because of the investigation, advance in investigation. Catch them early because you can, after the clinical diagnosis of inflammatory disease, you can get the CRP, ESR, and depending on the activity, you can know how active is the disease and treat it accordingly. But don't forget the physiotherapy part, the exercise part, reduction in body weight, reduction, avoidance of tobacco. Can radiological progression in ankylosing spondylitis be stopped? Now, this, as it said, it may not be stopped. As for the science goes, yeah, what the slides have shown, if anti-TNF is used for about 8 years, you can show a slowing down of angspond, the syndesmophyte formation. IL-17, which acts via that pathway, that also has a very significant role in preventing syndesmophyte formation or slowing down possibly. But we must remember that angspond is a heterogeneous disease. All of them will not progress from non-radiographic spondyloarthropathy, which is only evidence on MRI, to the adult angspond form. Some of them will be non-progressive. So you have to think this is a heterogeneous disease where we have to judiciously use the drugs on the patient who are progressing. Are there prognostic factors that could predict bad outcome? Yes, a very high CRP, ESR. Then lifestyle changes, some patients not willing, they hang on to their tobacco. That is very important. Plus, all the other factors like obesity, metabolic syndrome, all of them, the comorbidities, which will definitely predict a bad outcome from the patient. They have to change their lifestyle. That is the gut thing. Can remission be induced in angspond if treatment with TNF blockers is started early? Answer is absolutely yes. That's why there's been a paradigm shift over the last few years, or the last 2 decades, in fact, since we got the anti-TNF. How can patients with early angspond be better identified in the primary care? The point is to keep, as a clinician, your eyes wide open. The way they walk into your chamber, that is the very important. Their gait, if it's a stiff gait, any part of the body, if it's a neck which is being affected more, the patient is slightly hunched up in the neck, or a stiff back, then you can catch them as soon as they come. And if the advanced angspond, I'm sure all our rheumatologists, the experienced ones, orthopedicians, they will definitely think about it straight away. You can, and the other important thing is to spread the awareness in amongst the general physicians, amongst our community care, so that they catch these patients early and do the needful. Is it possible to predict short-term treatment response to TNF inhibitors accurately in patients with active ankylosing spondylitis? As I suggested from the data, the slide there, which came last year, it showed that people with a high CRP, a high patient global assessment, definitely show a better response to and a high BAS diet if the TNF is early. But it's not 100%. They said 0.75 probability, etc. But that is a good thing for us. You know which are the patients are most likely to respond. Should one use biologics or tofacitinib for patients with rheumatoid arthritis naive to methotrexate? With rheumatoid arthritis is a different thing. I still believe methotrexate is the gold standard for people diagnosed with rheumatoid. Biologics or tofacitinib can come if they are resistant to methotrexate, intolerant of methotrexate, or they have gross side effects to methotrexate. Then the question comes of using something else as a substitute. In rheumatoid arthritis, you can use sulfasalazine, you can use even leflunomide, which is far less costly. Now we have the tofacitinib generics and obviously the biologics as a follow-up. So it depends on the scenario, the conditions of the patient, which is individualized, their economic status. That is very important because you have to remember their level of education. When you're using a strong drug, whether they will come back to you with the investigations every 3 months or 6 months, as you have advised, who are the people likely to drop out, that sort of thing. So it varies. Every patient has to be treated individually. How would you rate the clinical outcomes in AS patients treated with various types of TNF inhibitors? The important thing to remember, if it's purely axial spondylotropathy or a peripheral variety or a mixed variety, no associated skin lesions or colitis or uveitis, any of the four will do, which means adalimumab, golimumab, infliximab, or your etanercept. But if it's inflammatory bowel disease, or very commonly about 25-30 patients have active uveitis sometime, or even they present with uveitis, if they're HLA-B27 positive, you have the option of using monoclonal antibodies, which means adalimumab and infliximab. Etanercept does not fare very well there with uveitis or with colitis. Certolizumab pegol was not available in India. It isn't available, and I don't believe they will be coming. So that is the thing. For psoriatic arthritis, IL-17 stands out. That's a different class of drugs. What are the effects of anti-TNF alpha therapy on spinal manifestation and peripheral arthritis in patients with angstpond? They work very well. Most of them will having a touch of methotrexate along with it does help. It prevents antibody formation, but some of you can use them singularly as well. But the effects are definitely good, as they show. They prevent the progression of the disease over a period of time. But the patient has to stick to his lifestyle modification, the exercise, the avoidance of tobacco, etc. I believe that was the last question. So hopefully I've tried to answer all your questions.
Yes, sir. As I can see, there is no more questions. So, sir, on the behalf of Cipla Pharmaceutical, I, Kumar Kaushal, would like to give my special thanks to you, sir, from your precious time and busy schedule. You took out time and enlighten us with your knowledge. I would also like to give my special thanks to all the audience for taking out time and attending this meeting. Thank you very much, sir.
Thank you.